Okay, I think we're going to go ahead and get started here. Good afternoon, everyone. Thank you for being here. I'm Tiana Halcomb from Maxius. I have the pleasure of introducing Dr. David Urbanek. Dr. Urbanek is a board-certified oral and maxillofacial surgeon who practices in Greater St. Louis, Missouri. He completed his OMS training at Carle Foundation Hospital in Champaign-Urbana, Illinois. He earned his dental degree at Case Western Reserve University School of Dental Medicine in Cleveland, Ohio. And prior to that, he earned his master's degree with honors in applied anatomy at the Case School of Medicine. He also serves as adjunct faculty at Carle Foundation Hospital Department of OMS and A.T. Still University, Missouri School of Dentistry and Oral Health. Dr. Urbanek avidly lectures to the dental and OMS community throughout the country. He's authored several chapters in various OMS textbooks, and his surgical interests are in complex dental implantology, bone grafting, and soft tissue management. With that, it's my pleasure to introduce Dr. Urbanek.
Thank you. All right. Thank you, everybody, for coming. Hopefully we'll have a good time here. There we go. Okay. So a few things here. So I do some speaking for Maxius, who's sponsoring the lunch today, and then I also talk for Geishlich. I'm a clinical preceptor for the Osteoscience Foundation, and if any residents are in the audience, I behoove you to reach out to the Osteoscience Foundation and see if you can sign up for their clinical observership program that they have. And this way you can kind of get out of residency for a few weeks and come and shadow at different practices. It's a phenomenal experience. I highly recommend it. And then building off that, I was inspired by the Osteoscience Foundation. I started the Excellence in OMS Foundation, where we do something similar. Basically, our mission is to advance education among residents and novice oral surgeons through focused CE and clinical training. So again, if residents are in the audience and they want to reach out, please do. We can do some like live training, come visit the office, and also I can even come to your residency and lecture and do hands-on workshops and all that. We'll bring in pig jaws and all. It's pretty fun for the groups that I've done it with so far. So now we'll just get right into it. So we've got a lot to cover. So today what I'm going to do is just talk about just cases, and we'll start from basic to complex and how I've used BioExclude and these Amnion-Chorion membranes and just leveraged the unique handling capabilities that they have, and also the growth factors and antimicrobial properties. And I was able to use these in cases where it'd be difficult to use other membranes or biomaterials. So what is an Amnion-Chorion membrane, specifically BioExclude? But basically it's a dehydrated, de-epithelialized human amnion-chorionic membrane, and they procure this from living newborns via cesarean section. And in the literature, you'll see oftentimes that they misquote it. People a lot of times say that it's placentally based, and it's actually not the placenta technically. It's from the amniochorionic sac, or the amniotic sac, which you can see here. And then here's a gross specimen, because who doesn't want to look at this while they're eating lunch, right? So, but specifically, you can see the doc or the nurse here is actually holding up the sac itself, and then on the other end of the pole there is the placenta, okay? And that's the organ that is responsible for exchange of gases and stuff between fetus and mother. Now, what's interesting about the Amnion-Chorion layer is that's 100% fetally derived. And so with that, you're gonna have stem cells in it, you're gonna have growth factors and all these unique capabilities of it that you don't see in other tissue. And then as for the placenta is 50% maternally derived and 50% fetally derived. And then you can actually separate these two layers. You can see the amniotic layer separating from the chorion that's underlying it. And if you look at the ultrastructure of it, it's made up of several layers, all right? And then BioExclude itself is specifically from these 4 layers here, okay? So you have an amniotic mesoderm laminated to a chorionic mesoderm, and on either side of that you have a basement membrane. And that's important because now you have basement membrane on either side, so there's no orientation to it, there's no up, there's no down. It doesn't matter how you put this in there. And if you look at it, all the different components of the extracellular matrix, it has full of a lot of collagens that you find in basement membrane, okay? Collagen types, 3, 4, 6, 1, all right? Same with fibronectins and laminins. And the way to think about this membrane, what I consider it as, is a barrier and a carrier. Okay, so it has the occlusive properties of a traditional barrier membrane, but also it's a biologic agent. It carries growth factors with it. And to date, they found over 285 growth factors, and I'm sure they're going to continue to find more. Just 2 years ago, it was at 250. And so processing is very important because you want to try to preserve as many of those growth factors as you can. And so let's take a look at how they do that. So first, what they're going to do is delaminate the two layers. They're going to separate the amniotic layer from the chorionic layer and remove that intermediate layer. And that intermediate layer is just like a small little wispy area, and that's just basically represents the fusion of those two layers during development. And then they're going to deepithelialize it, and then process everything, wash it, whatnot, and then laminate things together. And again, you have exposed basement membrane on the top of the membrane and as well as the underside of the membrane. Now, in 2015, Koob's group did a study where they were comparing proprietarily processed amnion-chorionic membrane, the special processing that BioExclude goes through, with the competitors that were out there. And what they found was there was a 4x growth factor increase. Okay, it had 4 times the concentration of the growth factors as the competitors. And then in addition, what they did was they looked at the chorion layer itself. And what they found was there is a similar amount of growth factor content, but also the concentration of all those growth factors was the same. And that's important. And basically the only change here is the thickness, right? And that's important because bulk matters. So what they do is, when they laminate these together, now you have a thicker membrane, you have a higher concentration of growth factors that you're going to deliver to the wound. And so when you compare this to the competitors that are out there, because of their processing, they have at least 5 times the amount of growth factors that you're going to find in the competitors that are there. And it's these growth factors that are responsible for a lot of these unique characteristics that you're going to find with this type of membrane, specifically with like wound healing. Now, one of the things I enjoy about using this membrane here is the handling of it, okay? Some people complain like, oh, it's pretty thin and all that, but that thinness is actually a benefit, okay? Because this way you can put it in places where you can't normally put a collagen membrane. You can put it right up against roots, implants, healing abutments, all right? You don't have to trim it at all, but a lot of times what I'll do is I'll actually cut it in different shapes and kind of stack it and push it in and mortise it wherever I need it. You can leave it exposed, which is awesome because it's going to allow that quick epithelialization over a wound, like a socket, for instance. And then I also use it in combination with other membranes. I'll put it above like a collagen membrane to kind of add thickness to a wound as it's healing. So in perio, they're using this typically for like GTR procedures. And with these cases here, you can get that membrane tucked right up underneath the embrasure, under the papillae, around the roots. It's not going to affect it. And especially with peri-implantitis treatment, you can raise these small little conservative flaps, place your graft, and just close things up rather nicely. And I use them this way as well. So let's get into some cases here. So this is a 39-year-old female, and so she had failing endo on tooth number 8. All right, and she also has a history of an apicoectomy at this tooth. So you can see, she's got residual pathology. She also has a surgical defect here, with just basically a missing blown out labial plate. And on top of that, she had a very high smile line and was extremely aesthetically demanding here. So whenever I come across these cases, I always try to do them in an immediate fashion if I can, just to try to preserve the gingival architecture. But you can see here, there's just too much disease that was happening here. There's just no bone. It was going to be an unpredictable result. And on top of that, even if I tried to stick an implant in there, the longest implant I have in my arsenal is a 17 millimeter, and I can barely get it in. So this defect went basically right up to the floor of her nose. So, fate was against us here, so we're just going to do this in a delayed fashion. So when I approach cases like these labial plate blowouts, what I'll do is basically do socket preservation along with like reconstruction, so a GBR at the same time, okay? So I raise a 3-cornered flap, clean out the pathology, okay? You can see there's just like a little wisp of bone that's left there, all right? And then we place our bone graft, and I did a combination of cancellous allograft mixed with bovine xenograft and then PRP. And then on top of that, I layered my amnion-chorionic membranes. And so I placed several membranes over the facial portion of the graft, and then I placed several layers over the crestal area as well. And then I close it. I don't try to force primary closure, okay? I don't want to close it under tension. I don't want to distort the anatomy. I just leave it as is, and then I let the epithelium do its job, okay? It's just going to migrate right across the membrane itself. And these membranes have a high concentration of laminins, like I said earlier, but specifically laminin 5. And if you look at the studies from back in like the 80s with Terra Nova, they found that the oral epithelium has a high affinity specifically for laminin 5, and it really facilitates the migration across the defect there. So I typically give these about 8 or 9 months to heal. So she's back at 10 months, and you can see like the soft tissue envelope has healed very well at this point. Now we're gonna circle back to this case in a second here, but this is just a one-off thing. This is something I do on like a daily basis here when I'm doing these labial blowout fractures. Defects, excuse me. So here we have tooth number 9 was removed. I grafted it. In this case, I used a double membrane technique where I placed a collagen, like a type 3 porcine collagen membrane over the graft, okay? And I placed it over the crestal area as well. And then on top of that, I put layered amnion-chorionic membranes over that, okay, to facilitate healing of the wound and also that quick epithelialization, okay? So we see at 1 week here, that's not exposed bone graft. If you look closely, what that is basically the membrane, and then on top of that is just like a thin fibrin network that's covering that, okay? And then at 3 weeks, you can see the mucosa is quickly going over that fibrin meshwork here. And then I had him back at 3 months for another issue, and you can see that the mucosa here is rather healed, okay? Full granulation, and then over time, like I said, I'm gonna give this a few more months here, probably another, 5-6 months to heal. That tissue's only gonna thicken with time, okay? Same thing, 21-year-old male, similar situation. We took out tooth number 9, grafted it just like that, closed it up, okay? At 2 weeks, you can see nice healing at that point. Usually I'm taking stitches out at week 2 or 3 or so if I place longer lasting stitches. Then we have them back at 10 months, and you can see the soft tissue envelope is healed up very nicely, okay? Now what's nice about these membranes too is they do deliver growth factors to the wound, okay? So that's gonna help with the soft tissue healing. The question is, does it really help with bone healing itself? Well, maybe not directly, maybe just a little bit, but how do you quantify that? How do you study that? But my belief is the faster you can get the soft tissue envelope to heal, faster you can get that periosteum to regenerate, you're gonna have better underlying bone growth. And so we see on our x-ray here, at 10 months when I did a workup for implant placement, we had significant bone growth in this area, okay? So plenty of bone to place an implant. And I'm seeing this quite often with these cases where I'm doing this on. So here's another case, a 22-year-old, impacted tooth number 22, and it was on a 14-year-old male. And you can see where this tooth is positioned, okay? It's rather crestally, he's missing facial bone in this area. Now, this kid, he was severely autistic and nonverbal, okay? So normally we would do a orthodontic treatment in an E and B here, kind of chain ligate and bring that tooth up, but he wasn't a candidate for ortho, so our treatment plan was to remove this tooth. Okay, so we do our incision, sulcular incision with the release. You can see where this tooth is. So when we get this tooth out, you're gonna have a significant defect on the facial aspect of these teeth here. Okay, so if I were to place a collagen membrane, that'd be kind of hard to kind of get it fixated where I need it and everything and not have it get too close to the wound margin and touch the teeth, but that's where these amnion-chorionic membranes are nice because you can just cut it to shape and then place it in there. So typically what I'll do is I'll take a bigger membrane, maybe like a 20 by 30 or so, that's their largest one that they have at the moment, and cut it into 3 pieces, and then I just kind of place it where I need to. And you want to stack it, thickness is better. Again, it's all about like providing like a higher concentration, higher dose of growth factors to the wound. So we get primary closure here, okay? In this case, I just use chromic gut. And so, at a week and a half, we're looking at it, and he's getting a little bit of like separation of the gingiva from the tissue, and just the stitch that I was using, it looks like we had a bad batch of it and it just wasn't holding tension as much as I like. Maybe some patient factors went into it as well, maybe the mentalis pool or something. But point is, we were getting a little bit of, opening of the wound itself, and I was worried about bacteria getting down in there and infecting and colonizing our bone graft. But fortunately, with having that amniotic membrane down there, it did protect the wound and allowed the underlying tissue to granulate. So when I did inspect this area, the base of the wound itself was actually sealed, even though I had, the sulcular epithelium was rather mobile in this area. And then at 2.5 weeks, I was just watching it closely. You can see new growth happening. And then at 4 weeks, you can see everything has just kind of regenerated and sealed up. And he wanted to heal beautifully. So now, probably the most common use for these membranes is for socket preservation. And so typically with these, we'll get the tooth out, graft it like you normally do. And then you can take, different sizes of membranes and pack it in there. Some people just use like an 8x8 or something for, tooth number 7 here. Typically what I like to do though is utilize the thickness of it by putting a bigger piece in there and cutting it up, okay? So I'll take a 15x20 piece membrane and I'll cut that into 6 separate pieces and then stack it. And then typically what I'll do is I'll pick this up in like some cotton pickups and then do like a flash hydration of it, okay? So a lot of times I'm putting these in the dry state, but when I'm stacking them like this, it's just easier to flash hydrate, just dip it in some saline, or you can dip it in some like liquid PRF or something, and then 3 pieces go right in there and I kind of just like push it in where I need to. Then I'll take the other 3, kind of hold them together like that, dip it, lay that on there. If you have extra excess fluid or excess blood, just take, maybe like a moist gauze in your cotton pickups and just kind of like dab it and just kind of wick that away, okay? And it won't take the membrane with it as long as it's moist. So I place a suture, and usually I do not just like a figure 8, but I call it like a spider web. I kind of put the suture in and I crisscross over a few times just so that it's nice and supported. And then at 2 weeks, you can see that the wound is healing, rather nicely, okay? And usually these smaller, sized teeth, it's gonna heal rather quickly. A molar is gonna heal, maybe after another week or so. It's usually like a little bit of a delay because it's a bigger area to granulate, okay? And I'm not the only one seeing results like this. If you look at different publications, other authors are having similar results with closure, okay? And again, a bigger socket's gonna take just a little bit longer for all that to close, but what you can see is, a nice fibrinous base at the bottom. You can see the epithelialization that's happening over the socket itself. So now there's been recent research that's been out there that suggests that stem cells themselves may not be as important to wound healing as the growth factors that they secrete themselves. So and that's actually a good thing, right? Because now we don't have to worry about trying to preserve stem cells in our offices and all that. We can just have growth factors on hand that we can place into a wound. So if there's a way we can actually just deliver growth factors to the wound, maybe we can call in the native stem cells and then upregulate them to secrete more growth factors and create this feedback loop and upregulate our healing. And that's kind of where we are now with tissue regeneration. So let's get back to our first case here. So this is that 39-year-old lady with the tooth number 10. Okay, so if you remember what the case looked like here, we did our extraction, our GBR, we got closure. Okay, so I had her back at 8 months here for our workup. Okay, and our plan was to place an implant with an immediate provisional on it. Okay, just for to help with aesthetics and everything. She had a favorable smile. And occlusion and all, and she was a compliant patient. But what I like to see here is the bone graft. You can see how nicely shaped and contoured and a nice, dense, homogeneous fill of our graft. And here's her smile line, if you guys were wondering, right? And she's one of those ones where, she's looking in the mirror, she knows, very discerning eye, an eye sharp as a dentist's eye, I would say. So, the bar was set very high here. So we go to surgery. In this case here, I did a paracrestal incision. I placed the implant in a guided fashion. Make sure you get that implant deep enough. And so you can see the implant's slightly subcrestal, but we don't want to leave it there like that. So what we actually want to do is trephine the bone just a little bit to profile it, just to allow for preventing impingement of the healing abutment, impingement of the provisional crown and the final crown, okay? And with these anterior cases, I like to thicken the soft tissue, and typically I'll use like a connective tissue graft or even a collagen matrix here. So in this case here, I did a collagen matrix. And so what I do is I make an incision through the periosteum and do a supraperiosteal dissection, create a pouch into which I place this collagen matrix. So the matrix is in place. And then we got this excess gingiva to deal with. Now you got some options. You can cut it away, or maybe we can put it to use here. So what I ended up doing is rotating a mesally based finger flap here, so a Palachi flap, if you guys have heard of that. And then I inset that along the mesial aspect of that implant to kind of rebuild and bulk up that papilla. place some sutures, try to overdrape the tissue just a little bit. I use some Vicryl here, some longer lasting suture to kind of really support the wound. So 2 weeks go by, you can see there's some edema, but everything is healing very nicely. And at 4 weeks, things are settling out a little bit. I remove my sutures, and then she goes on to heal, very favorably. So we're here at 3 months. That's her provisional crown. And then it was just a ship shot for the dentist to restore. So all he had to do is just switch that tooth out. Most of the work was done for him. And great aesthetic results. She was extremely happy. Dentist was very happy. And if you remember where we started, we had a very complex case, a lot of challenges that we were working against, but with proper grafting, soft tissue, healing and maturation and manipulation, we got an excellent result. Now, oftentimes I'm asked about my thoughts on like PRF and if I use it, and then specifically how does it compare to BioExclude. And so I just started using PRF about 2+ years ago, and I like it. I like it a lot, and there's a lot of benefits to it. However, there are some drawbacks to it. You have to recognize that there is a little bit of bulk to it, okay? So if you already have a wound where it's full of bone graft and you have other membranes there, are you gonna really be able to stick more PRF membranes over that? Also, the handling of it, it's kind of floppy. Sometimes it rolls up on you. It's slippery. So if you're already putting that in, trying to close your wound, your soft tissue over that, sometimes it squishes out and everything. So there's some issues with it, but nothing terrible. But the biggest thing I find is the variability, right? So some patients just have terrible veins. You just can't get a good blood draw on them. I don't know if you guys have come across this, the case where you're looking to do, some PRF and you just can't get a good, I can barely get the IV in to give drugs. I'm not going to be able to pull any blood out of that, okay, as that thin lumen vessel just collapses around your cannula, right? And then the other thing to realize too is, a lot of these patients here, some of these older ones have different platelet counts, right? So they're not going to have as many growth factors inherently in their blood, right? And these are the patients that we need it the most on. And then on top of that, it's not a true barrier. It has some barrier characteristics, but the majority of people out there believe that it just isn't a true barrier for like the occlusive properties. Whereas BioExclude is going to have those nice handling characteristics. It's thin, you can put it where you need to. It's consistent, right? You always have it on hand. You can just take it right off the shelf. And then you got all the growth factors that are in there. And then one thing that in particular that I like about it is its antimicrobial properties that are inherently in the membrane itself. So what I'm doing now, when I'm doing cases, specifically, socket preservation, or if I'm, grafting the jumping gap for immediate implants, is I'm going to combine them. So I'll place my bone graft, and then I'll put BioExclude over the bone graft, and then on top of that, I'll bolster that with a PRF membrane, kind of like a patch that goes over it. And that's going to do several things. It's going to increase the amount of growth factors that you're delivering to the wound, but also it's going to physically protect the Amnion-Chorion membrane that you have there, okay? And I've seen great results with this where things are healing even faster than just with Amnion alone. So that's the new way that I'm using this. And then one of the theories they have too is the PRF membrane is kind of like a scab, if you will. And so the mucosa and the fibroblasts and everything are preferentially going to want to migrate underneath the PRF membrane, whereas the amnion-chorionic membrane, think of it as a basement membrane analog, and you're going to have epithelium want to preferentially migrate over it. So if you think about it, you kind of have like this sandwich, a tunnel, if you will, where the epithelium, that healing tissue is going right in between those layers. So can I prove it? No, but that's the theory that's out there. So it makes sense, but who knows? So I mentioned earlier I like to use these with immediate implants, and so I found great value with this when I'm trying to like graft the jumping gap and get soft tissue closure around like a custom healing abutment or just a regular healing abutment. So let's look at a case here, a posterior implant. So 76-year-old male who shows up has a fractured tooth number 30 that's non-restorable. So he had great anatomy for an immediate implant. So how I approach these typically is I like to leave the roots in. So I cut off the crown first, and I use the roots basically as like a drilling guide. Okay, it's hard to just drill when you have like that inner radicular bone and you got air on each side, your drill wants to slip off. So I find if you leave the roots in there and you just prep right through them, it works really well. So you can drill between the roots into the bone, or if you want to make sure your angle's just at the right spot, a lot of times I'm just prepping right into that mesial root, okay? And actually the burr, as it drills down, and kind of luxate the roots a bit, it makes it a little bit easier to remove when you take it out. It just usually want to slide right out. So you can see my my drill, my twist drill, right in between the roots, right where I want it, with a lingual bias. So finish my osteotomy, roots come out, place my implant. Then I'm going to graft the jumping gap with bone graft material. And then on top of that, I'm going to place my layered amnion-chorionic membranes. So typically I'll take, anywhere from maybe like an 8x8 millimeter membrane, cut it in 2 pieces for like small sites, or for a molar like this, typically what I'll do is get like a 15x20 and then cut it in several pieces, layer it and mortise it where I need to. Then on top of that, I'll take a PRF membrane, and what I'll do is usually just kind of cut it to shape and maybe make like a little like scarf graft, if you will, or sometimes just like cut a hole in the center of it and do like a poncho graft with it, and then put it over that healing abutment and then sew that in. And then typically what I'm seeing here is just excellent soft tissue healing. And what's nice is, the healing abutment is going to take up space, so you're actually going to get faster granulation and closure of this wound around that healing abutment. Okay, and you can see that's not exposed graft in that 2-week photo. That's maybe some graft that you can see through the thin tissue, through this thin membrane and that granulating tissue. Okay, and so typically with these, I'll let them heal for about 4 months or so for integration, let that bone graft do its work here, and then I send them to the dentist. So he's going to be restored very shortly here. So, and then again, you're going to see, nice consolidation of our bone graft, no marginal bone loss. Okay. So similar stuff with an anterior implant here. We took out a tooth, placed the implant, and for some of these cases where I can't do a provisional crown immediately, I'll just place a custom healing abutment. So we're going to graft the facial gap with bone graft material. I'm going to place like a FibroGuide collagen matrix or a connective tissue graft. In this case, I use that collagen matrix. And then on top of that, I want to seal it and prevent bacteria from kind of getting in the wound and getting into that collagen sponge, if you will. So what I do is I place an 8x8 membrane, and I just cut it into 2 pieces and layer it over there. Okay, and that's going to help support the soft tissue that's over it. It's going to form an antimicrobial seal, if you will, and really upregulate the healing, try to get that epithelium to attach to that titanium healing abutment as fast as we can. So you see at 3 months, the soft tissue has healed up nicely and matured. And then we go to final at 4 months. We have an excellent result here. I'd say, probably a 13 or 14 out of 14 pink aesthetic score. The patient was very happy with that. And then the biggest thing I like with the results that I get with these is it stands up over time. Okay, so it's not just, hey, you got the final crown in, we're done. I usually follow these patients for a year or two to see where we're at, and you can see, there's no gingival midfacial recession, there's no marginal bone loss on our X-ray there. So let's take a look at another case here. So this is a 48-year-old female, and so she presented to me by her dentist. And so she had failing dentition, high caries risk, and so our ultimate plan for her was to, eventually remove all her teeth and place her in implant bridges. And so to get her ready for that, we're going to do some posterior bilateral maxillary sinus lifts. Okay, but if you look at her X-ray closely, you can see all these incomplete septa throughout the sinuses. All right, and as we know with these septa, these are high risk for perforation. All right, and so whenever I have these cases and I have a perforation, I actually don't worry about it anymore because I can just place these membranes to seal things up. Okay, and then if you also look too, you can see there's an errantly placed implant that's just going straight up into the sinus. So we're going to have multiple perforations in this case, as we go through it. So how can we mitigate that? So I start on the left side, so do a lateral sinus lift, do my large window here so I can get control on either side of all those septa that she has. And then raise my membrane. You can see I already have a few perforations, and especially one over where that implant apex was. And if you look at the implant itself, you can see it was, rather errantly placed. It's got a buccal incline as well as a mesial. So this one, it barely integrated. Just all the anti-rotational features weren't even in bone at this point. So it was just an easy way to back it out. And then I go to the other side. In this case here, I did a double membrane technique, try to just save as much bone as I can and go in on either side of the septa that she has and just elevate things. But if you look at her X-ray closely, you can see, I have at least 3, perforations and tears in her membrane on either side, right? So, how can we fix this? Well, what's nice is these membranes here have, like a good handling and adhesion. So basically what I'll do typically is just cut these membranes into, different pieces, different sizes that I need, and I just put them in the window. If you try to put it in as one piece, it's kind of hard to work it and get it in there, and it makes it difficult. It'll tend to curl on you, especially if it hits some humidity. It'll start wrapping on you and everything, and then it's hard to unfold it. So a lot of times what I'll do is just cut these into strips, something like this, 3 or 4 strips, and put them in the dry state and just kind of just lay it where I need to and just kind of lattice it on itself and just seal up the perforations that you have. So that's what I ended up doing with this case here. So I took 4 pieces and cut it into different strips here, and then I placed them on either side here, okay? And so remember our perforations, and then I just place it where I need to, okay? And just let them like stack on each other. Don't put it in and pull it out. Once you put it in, you know it's in, okay? Don't pull it out, just let it stick. And once you reconstruct the floor of the membrane, you're gonna see that the membrane will start bellowing again, okay, after when they're breathing and all. And it works very, very nicely. So just as a little schematic here, you know, little perforations, you know, you can just take like 1 piece and put it there. Usually I'll put a couple there. Thickness is good, bulk is good, okay? And you know, you typically want at least maybe, you know, 5 to 8 millimeters of periphery around your tear. Now, if you have bigger areas where there is just like a big tear, you know, you have some sinus pathology, you know, just terrible sinuses, people with like real atrophic mucosa, you know, that gets tough. But what I'll do is actually just take several of these pieces and just layer them and lattice them on themselves and just kind of like cantilever over and then just keep stacking. Go from like known to unknown, okay, intact to missing basically. And then in cases that are really large, what I'll actually do is I'll, you know, kind of wrap the membrane around the posterior, okay? And you want to have a little bit, you know, on the bottom of the sinus floor there, because when you pack your graft, it's going to really just lay in there nicely and prevent it from like flipping up on you, okay? And then you just put your graft in. Now, when you do place the graft, you know, do it gently, of course, because these membranes, they're nice and they adhere, but they're not totally impervious. They're just gonna just push through if you push too hard. So this is why I like to use sticky bone or PRP when I do this. It just really helps kind of hold that bone graft in place and everything. So now, if you don't need to fill up the entire sinus and you have a large tear, you know, you can always just stop it short and just do like a little wrap like that and then place your graft as you need. Okay, and then hopefully everything just epithelializes right after, and typically that's what I'm finding. Now, when I have these big tears in the sinuses, I always worry about infection. You know, there's a lot of sinus bugs up there, so you know, how do you protect your graft from getting infected from those bugs? But this is where I like the antimicrobial properties of these. And so they've done analyses of the different peptides that are in there, and there's many different peptides like human beta defensins and other ones. It has all the components of complement. And there's several studies that are out there. There's a new one that just came out in 2024, but they're finding that these membranes have these inherent antimicrobial capabilities, and they've been proven to be just as bactericidal as tetracycline against AA, strep mutans, strep oralis, and also had very high antimicrobial efficacy against strep gordonii. And so we'll just look at the studies real fast here. So what they did was they grew the bacteria and then they inoculated them on collagen membranes, Amnion-Chorion membranes, and just like negative control paper discs, okay? And then they cultured them, and then at 12 and 24 hours, what they did was they removed the bacteria by putting these little like sonicating pipettes here and culturing them. And then what they were finding is for the Amnion-Chorion group here, they had 0 bacterial growth at 12 and 24 hours. And that was the same as with the positive control of just tetracycline. Whereas the negative control and the collagen membrane you had normal bacterial growth. Okay, and if you look at the kill curves here, you can see the tetracycline group and the Amnion-Chorion group had absolutely 0 growth. And you can see there's only one line because they're all superimposed on each other here. So now there was another study out there where they were looking at placing the bacteria on different membranes. Okay, they looked at amnion membrane and pericardial collagen membrane in different states. Okay, so they had it just kind of sitting on just a culture medium. They had it on agar, and they also had just like planktonic bacteria floating around, seeing if it would attach to the membrane here. So, and what they found was there was no growth in for strep gordonii in the areas where on the amnion-chorionic membrane here. So, and when you look at the viable count assay, again, no growth, okay? And when they did their disk diffusion assay, you can see at the amnion-chorionic membrane, there was a small zone of inhibition around it, all right? Now, if you look at the porcine pericardial collagen membrane that was impregnated with tetracycline, you can see this very large zone of inhibition, right? But that's kind of artifact, if you will, because that is just the runoff of the tetracycline from the membrane itself, okay? Whereas in the amnion-chorionic membrane, all those antimicrobial peptides and proteins are fixated within it, okay? And then in the study in 2004, they're more closely looking at these different antimicrobial peptides, and they looked at these 4 in particular by themselves, and then they also looked at them in conjunction. And what they found was each of these peptides and proteins did effectively kill Strep gordonii, but it was done in a dose-dependent fashion. But when they combined them, it was actually even more effective. And so that kind of goes back to the layered concept here. So if we can deliver a higher concentration of growth factors, we can deliver a higher concentration of these antimicrobial peptides and proteins, that's going to definitely benefit you. So if you guys are getting into using this, I would highly recommend doing this in this layered fashion here. It makes a big difference in healing and in handling, if you will. Okay, so back to our case here. We placed our membranes, placed our bone graft, and then I placed more membranes over the window, and then I closed the soft tissue. Okay. So at 1 week, you can see the soft tissue is non-inflamed, looks nice, closed, no wound dehiscence, all right? And then at 5 months of healing, you can see, nice consolidation of the bone graft, good vertical growth. And so the next stage was to start doing the implants, extraction and implants. Okay. So next phase of the treatment plan here, we're going to take out tooth number 3. We're going to place an implant, or an immediate implant at 3, and then we're going to place an implant at site number 4. So implant gets placed, bone graft goes in, cover my graft with the amnion-chorionic membrane, and then on top of that is where I'm going to place the PRF membrane. So we get closure. And again, I don't try to force primary closure. You see how large the socket is for tooth number 3. I just leave it where it is, okay? And the idea is just to have all that keratinized tissue grow in, okay? We don't want to rob for it. We want to try to, augment and grow as much soft tissue as we can. On the other side, I was going to place implants at, I guess it'd be 13 and 14 is what we were going to call it. And so she had a thinner ridge on this side, so I was going to plan a ridge expansion here, ridge split. So, I start with my 2 osteotomies, I under prep it, of course, and then I take a piezo knife, do an incision through the bone, and then basically open book it. Place my implants, and then in that gap that we created, I did an interpositional graft here where we placed particulate bone graft in there, and then we covered it with our amnion-chorionic membranes. All right, and if you look at in the more apical portion of the picture here, you can see I did a periosteal incision, supraperiosteal dissection, so I could advance that flap without tension. And we get nice closure. And then the idea here is to have the growth factors help the maturation of the wound and seal up the wound closure. Okay, post-op, immediate post-op. All right, so 4.5 months post-op. You can see here we have adequate healing here. We do have little atrophy of the soft tissue on the buccal here. You can see where the mucogingival junction is. So the question is should we augment that? Should we do a free gingival graft here, or we can do something else? So in this case here, I did an apically repositioned flap where I was going to take that tissue, I was going to rob from Peter to pay Paul, and then move that to the buccal of these teeth during my uncovery. So what we ended up doing here was a split thickness incision and a dissection, and then reposition that flap apically. Let it heal. And at 1.5 weeks, you can see things are healing and maturing nicely. We get good mucosalization. At 4 weeks, things are maturing. And I want to draw your attention here to implant 3 and 4, specifically implant 3. So we're 5 months out from implant placement. Remember, this was an immediate implant that we placed. And you can see we have nice, healthy, soft tissue that is sealed up around that healing abutment. Okay, and the underlying bone graft down there is going to be good as well. Okay, so here's our last case. So a 68-year-old female, and so she presented with failing implants here. So you can see these implants have some issues, okay? So, if we look at her clinically, implant number 7 was, extremely apically positioned, all right? She's got some soft tissue loss as well. If you look at implant number 11, same thing. This thing has pathology at its apex, some of those periapical granulomas. And she also has bone loss and soft tissue atrophy around the facial portion of that margin. Can you guys hear me okay? With all the completion? Okay. Okay, so if you look at the oblique views, you can see, we got some issues here, okay? I don't know how the dentist restored it, but that was good luck, or good job to them, because this is a tough one. But the problem is when you have, and this was cemented, by the way, okay? When you have cemented margins, that apical, you're gonna have some type of cement retention, you're gonna have some issues, okay? If you look at number 11, you're already seeing mucositis and dehiscence and atrophy of that soft tissue there. So our plan was to remove these implants, and so it was just a cemented restoration. So basically I just put some forceps on and just kind of fractured it, brought it off. Okay, and you can see implant number 11 came right with it, backed out pretty straightforwardly. Okay, implant number 7 remains, so what we're gonna do is just open up and get this out. And so I removed number 7 with a trephine, all right, and then you see how we're left with these class 3 two-walled defects. Okay, so significant horizontal and vertical alveolar atrophy and surgical defect there. So in these cases, you have the choice of grafting these immediately or just letting the soft tissue heal. These implants were not infected, there wasn't pus or anything like that, so I made the decision to do an immediate reconstruction for it. So I want to try to just save some type of contour of the bone. I want to try to get some soft tissue just to heal over that bone graft and prevent that soft tissue contracture that you typically will get here. So we place our bone graft, and then here I did the double membrane technique. I placed collagen membranes over my bone graft, and on top of that I layered the Amnion-Chorionic membranes. Okay, and this is important because in those areas where those implants had their dehiscences, we're trying to bring that mucosa together, and I find those areas just notoriously just don't heal too well. Okay, you just want to open up on you. So I was doing everything I can just to try to get wound maturation. So here's our closure. We got primary closure in certain areas, and then right where those dehiscences were, I try to bring that tissue together. Like I said, these notoriously just want to open up on you. So at 3 weeks, you can see, everything's looking great with site number 7. However, site number 11, you see that natural dehiscence, where things open up. Okay, now if you look at the base of the wound here, you can see some bone graft, but to me it looked like there was a little bit of that fibrin tissue and maybe a little bit of membrane that's left there, and there were no signs of infection, no erythema or tenderness. So we didn't have to do anything at this point in time. I told her we're just going to watch this closely. Hopefully we'll see this thing granulate close. We'll see what happens. Okay, so. And the other thing to look at is too, you have a little bit of wound dehiscence and contracture right at the incision line at site number 12. But you can see healthy granulating tissue under there. So basically it's like a race between wound contracture and dehiscence versus granulation, but there is no exposure of any graft in that area. So I give her a couple more weeks, get her back at 5 weeks. And at this point here, I decided let's do a wound revision. Let's try to get some primary closure. Let me help the cause. I didn't want to just let this cook, because at this point you can see, some bone graft that's there. I'm sure my membranes are gone at this point. I'm sure they've, degraded, and I just didn't want retrograde infection and colonization of my graft. So if we can help the cause, let's do it. Let's see if we can get in there. So what I did was I freshened the wound margins with a little elliptical incision, kind of removed any colonized bone graft that was there, and then undermined my wound margins, and then took a 15 by 20 bioexclude membrane, cut it up into 6 pieces, and then just layered that in there over my exposed graft, and then attempted primary closure here. We did a horizontal mattress just to try to move things closer as much as we could. Okay, so at 4 weeks, we have success here. Now you can see like a depression and all, but if you look closely at the base of that wound, that's mucosa. All right, so we were able to successfully protect our graft at this point here, and then we just got to give it time to heal. So at 10 weeks, you can see how the wound defect is shrinking. It's becoming more shallow. Okay, and then we're at 5 months now at this point here, and we're just kind of watching along. And so, we're going to get ready to start planning the next step. However, unfortunately, she was just recently diagnosed with it was non-small cell adenocarcinoma of the lung, and she was going to be starting chemotherapy and immunotherapy. And so thankfully we were able to get the soft tissue to close and get that healed before she began all that, but I still have bone graft in there. We're only 6 months out. We still have more time for that to heal. So I was worried about what all those chemotherapeutic agents were going to do to the graft. So we gave her time, just get that taken care of. So fortunately she beat it. She's in remission, got past all the therapy. And so we see her back at a year. and then time to start planning implants at this point here. So we do this in a prosthetically driven fashion here. So I send this to a lab. We work on designing the restoration ahead of time, and if we look at our bone looked favorable. Okay, now when we go to plan these cases, you're always going to overestimate the amount of bone you have when you're looking at it on the cone beam. Okay, you're always going to be a little disappointed when you go in and open up the patient, and so I was planning for that. So most likely I was going to be ready to add some extra bone graft in this case here. So we're at 1.5 years now. So we did this in a guided fashion, and what I like to do is raise flaps so I can see the bone, I can get the implants at the proper depth, I can augment bone as needed. All right, so my incision design here, I decided to raise 2 different flaps, and the reason I left this like central strut of attached tissue was if I were to place the implants and not do any grafting and just do an apically repositioned flap, I have something fixed to sew my anterior margins to. Okay, so a little strategy there to kind of keep it where I wanted it. So start raising my flaps here, and as soon as I get past the crest, I raise them in a full thickness fashion to a point, and then I was looking and I was seeing, yeah, there is some residual defects here. I'm going to have to do some simultaneous bone grafting at the time of implant placement. So then I transitioned to a split thickness incision. All right, and you can see the periosteal incision underneath the flap there, so I can mobilize those flaps and close them, with that additional bone graft material that's there. So I prepped the sites, placed my implants, and you can see there was some fibrous ingrowth into those grafts, just some non-fully consolidated grafts, with all those chemotherapeutic agents that just didn't allow the bone to heal perfectly, but I had enough for us to get the implants in. So you can see some exposure of the threads in implant number 7 and implant number 12, but not a problem. That's a very predictable thing for me to graft, so we added bone graft material there. And what I did was I lifted the periosteum a little bit and packed that bone up under the periosteum, and then laid the periosteum back down. And then on top of that, I placed Amnion-Chorion membranes and then closed my flaps. And we just wanted primary closure at this point. Okay, just let everything heal. And I give it a good amount of time to heal before we come on back. So, at 1 week, we're looking good, not much inflammation, no wound dehiscence. So I gave it about 4.5 months to mature, and then time for uncovery. Now, when I was looking at the case, I can see, there's a little bit of shallowness in her vestibule, okay, and here's our mucogingival junction, right? And so when I go to uncover these implants, I want to have an adequate amount of keratinized tissue on the facial, okay, to protect it. So, there's different ways to do that, but what I don't want to do is just simply uncover it and then end up with a case like this here. So this is another patient where I was referred this patient. Implants are already placed by another oral surgeon, but you can see, there's mucogingival defects all over. There's no keratinized tissue. So the dentist, saw this, and rightly so, was like not too happy about it. It's like, okay, we need to fix this here. So patient came my way. What can we do? So the implants looked like they were in good position. They were restorable and prosthetically good, but just the soft tissue needed to be augmented. So what I ended up doing for her was just bilateral free gingival grafts, just to really thicken that tissue, get that phenotype conversion, add keratinized tissue to the facial of those implants. And so at 1 year, this is how she healed. Tissue quality is excellent. It's thick. It's fibrotic. There's no mucositis. The dentist was very happy. Because he got a good restoration in there. But if you look at it, the color match isn't great. They're always going to lighten up with time. All right. Now, fortunately, she has a low smile line, so you're not going to really see that. She's not going to see it. But is there a better way to do this? And this is where a strip graft comes into vogue here, and that's where they come handy. So we look back at our case here. All right, I want to augment this tissue, and so that's what I decided to do is a free gingival strip graft. So I made an incision at the mucogingival junction, okay, and then a split thickness dissection. Basically, we're doing like a vestibuloplasty in this area here, all right. And then if you look at the 2 implants on the patient's left side here, number 11 and number 12, she had nice thick keratinized tissue in this area, so I didn't want to just cut that away and waste it. So what I ended up doing is raising a flap in this area. So I raised this in a full thickness fashion. So basically this one's pedicled anteriorly and pedicled apically off the connective tissue. Then I just insetted in around implant number 11. So then we go to the palate, grab our donor tissue. So I took 2 large strips from each side of the palate and then bisected those lengthwise. And let's see, palate was dressed with some PRF membranes. Okay, and this is how we inset it. So basically what we're doing is creating like a dam all the way across the maxilla, okay? And we're gonna allow that keratinized tissue to granulate from the superior and also from the inferior, and then it'll meet in the middle, okay? And we're just gonna expect new growth all the way across all that exposed periosteum that's there, okay? So I just inset this, I used 5-O-proline. And then in the area where the connective tissue was exposed, I placed a collagen matrix here, and that's going to allow that epithelialization to proceed. So we give it some time. And so usually I'll let these things heal for about 8 weeks before I send them to the dentist, all right? Now what's interesting is when you look at these strip grafts, you're going to expect some migration of the epithelium, which is kind of fascinating. I'll show you that in just a second here. But at 1 week you can see healthy tissue, all that fibrin that's there. At 2 weeks, it's maturing up nicely. At 3 weeks, you can see it's now fully mucosalized, okay? And we just got to give it time to heal. And so usually around like week 2, week 3, I start removing my sutures and all. Here at week 5, things are looking good. And then at 2 months, things are pretty mature where I can send them confidently to the dentist, okay? But look where our graft started and look where our graft ended. So whenever you're gonna do these, make sure you graft twice as far as you think you're gonna want. Okay, so that's a good pearl, because you will get that contracture and that migration. So sent her to the dentist. This is 4 months after the free gingival graft was done, and she's been in provisional, and this is at 3 weeks provisionalization. So these cases, rarely do we just go straight to final. A lot of the dentists I work with are pretty good, and what we'll do is we'll just like stair step it. So work everything out in plastic first. So we'll get this printed out of like PMMA and all that, and then they can put their stain it with the porcelain, with the pink gingiva and everything, and make sure aesthetics, phonetics, occlusion is all good before we go to final. So we'll leave this in her for a while before we go to final, make sure everything is good and she's happy and all that, and that's how we finished so far. Okay, so basically in summary, we've seen several cases, from basic to complex, and just how I will go about these cases. I try to treat them very comprehensively, but part of that is me leveraging all the different unique capabilities of amnion-chorionic membranes, with the antimicrobial properties, the growth factors, and then the handling. So at this point in time, we'll open it up for questions. If you guys have any questions, I think we're ahead of time, I don't know, perhaps. So everybody, thank you for your attention. Cool. And there's a microphone up front here if you want to come to that. It's pretty loud, it's hard to hear.
Hi, thank you for the presentation. I just want to know, have you ever tried the competitors' membranes?
Competitors' membranes?
Yeah.
I have used another one, and I didn't like the handling of it. It was kind of brittle, it was thicker. There was no up-down orientation. There was up-down orientation. You had to put it in a certain manner. And then if you look at the studies, the growth factor is just not there. So that's why, I'm more of a proponent of this style. Yeah.
Thank you.
Hi, wonderful presentation. Actually, I would like to know if you have any issues or you have ever had any issues with the immunocompromised patients, like in this type of cases.
With immune compromised?
Yes.
Yeah, I think it's an actual great indication to use it on it because you're adding growth factors, you're adding the antimicrobial properties to it. So yeah, there's no contraindication with that, I would say, but it's only going to help you.
Okay, and the time recovery has ever been like kind of the average, or has it increased or decreased?
That I can't say. I don't know.
It varies.
I'm sorry?
Does it vary?
Does it vary?
Yeah.
Well, I would think if you're immune compromised or just, not a great healer, it's going to be slower, compared to like a young person. But this is where you can kind of like level them up a bit. If you can add growth factors, PRF, Amnion-Chorion to a wound, try to just optimize it as best you can. It just makes sense.
Thank you.
You're welcome. Okay. Thank you for everyone's attention. If there are any other questions or you're a little shy to come up to the microphone, just stop up at the podium And then any residents want to meet, schedule something, let me know. I'll be here for a few. Okay, thank you guys.